Thank you. So continuing with the theme of surgical excellence, working out of Chennai, India, Dr. Ashvin Agarwal is the Chief Clinical Officer at Dr. Agarwal's Eye Hospital, an eye care group spanning over 170 locations globally. What is outstanding about him is that he's mastered a remarkable range of procedures and is able to handle a high volume of challenging cataract cases with skill and precision. So we would like to play his video where we will witness a range of challenging cases and will gain some practical tips that can be applied to routine cases as well. So can we have the video, please?
Hi, my name is Ashvin Agarwal and I'm the Chief Clinical Officer for the Dr. Agarwal Group of Eye Hospitals. Agarwal Eye Hospital is basically 194 centers spread across India, 180 and 16 across into Africa. We've taken ophthalmology to the doorstep of the people. Basically work on a hub and spoke model as patients coming in from the satellite centers into the hub or any challenging complex cases that need supervision or need expertise come into the main hub. In my personal practice, I'm dealing with cataract patients, cornea patients, refractive patients, glaucoma patients, and the most important being complex and challenging cases. So in my center alone, we're seeing about 700 to 800 patients a day. And if I'm seeing 700 to 800 patients a day, number one, I need doctors. I need to empower my team, my staff to actually deliver the results, number one. Second, time management and efficiency. Applaud and I recognize them for their, whenever somebody does really good on their time management and efficiency. Learn that, make it a standard operating protocol and share it with the others. And you're always there to serve the patient. That availability of time from your side, personal touch added to it, brings a huge amount of trust. Some of the tips and tricks that you got to use some basic principles in any of these challenging cases. When you see a coloboma in the Kansky book or a picture, it looks beautiful. But actually when you are working on a coloboma patient on the table in the OR, along with the phacoemulsification probe, you're also infusing BSS through the zonules or the weakened zonules in this scenario. That BSS goes behind the bag and into the vitreous cavity. It now hydrates the vitreous and causes a positive pressure. What I started to do, and I'm proposing this as vitrectomy assisted phacoemulsification, is to pre-place a trocar behind the iris before the case even began. Now what this does is, while I'm doing my phacoemulsification, if I have positive pressure, all I have to do is use a vitrectomy cutter, go behind and do a dry vitrectomy at 1500 cut rate, port down so that you're not touching any of the capsule, just for about 7 to 8 seconds, and now come out. What you will get is a deepened chamber, and now you're protecting your endothelium, you're protecting the posterior capsule, you're protecting any vitreous from coming into the anterior chamber. A lot of protection mechanism just by doing a 7 to 8 second dry vitrectomy in these scenarios. You could use this same vitrectomy assisted phacoemulsification in multiple reasons. Aqueous misdirection, intermittent cataract, high pressure glaucoma patient with angle closures, multiple reasons where you could use this. In intraocular lens drops, there are different types of intraocular lenses that can drop for multiple reasons. When they drop on the retina, the old techniques that people used to use was using intraocular lens forceps. But remember, the forceps were not made for intraocular lens drops. They were made for holding intraocular lenses and doing sutures or something like that. Now what happens is, when you have, for example, a plate haptic lens on the retina, the forceps works in a principle which is like coming up, it closes while coming up. So you actually have to go deep into the haptic and then hold. So only when it comes up, Now this small trick changes the game when you have a plate haptic lens. When you have a plate haptic lens and a forceps that works on the upward motion of its closure, it would not work. And that's what I faced. So I started to do something called as the extrusion cannula assisted levitation. It has a silicone sleeve inside. All I did was remove that silicone sleeve. Now that made it a wide bore lumen with a metal rod. Now all that I have to do is go on top of the optic, nowhere going close to the retina at all. Obviously all this is after doing a core vitrectomy thoroughly. Go on top of the optic and just aspirate the foot pedal at 400 mm. When you aspirate that, it would stick to the optic just like a fish and a spear, and it would bring that fish all the way up into the anterior chamber, and you can explant it or you could cut it the way you want. So in zonular dehiscence, when I'd see a zonular dehiscence, if it's a traumatic case, which is the most easiest, I would look at the amount of clock hours. If it is anything less than 3 clock hours, I would do a simple CTR or a capsule tension ring and put the lens in the bag. Anything more than 3 to 6 clock hours, I would place a segment, a Ahmed segment into the eye and attach it to the sclera using a double flange technique. Anything above 6 clock hours, I usually tend to do a glued intraocular lens. It is far more stable in an eye for 10 years out, and I've got 10 years of record to show that glued IOL in these scenarios are far better than doing 2 segments. If I have a completely dislocated bag, that means more than 8-10 clock hours, I would definitely just ECC that whole lens and definitely do a glued intraocular lens directly instead of trying to save the bag. Nowadays I do a biplanar incision along with a small Wong pocket. Excellent tip, because now I have 3 ports of doing stromal hydration. One is inside the Wong pocket, 2 of them are on the side of the wound. What that does is it presses on the upper lip of that wound downwards as soon as I hydrate that Wong pocket, and the 2 sides of the incision, if I'm hydrating that, it covers the other 2 sides as well. This has a very, very nice approach. 1 for the wound leak, 2nd for the astigmatism that I might cause at the end. The most annoying situations for a surgeon is when they have finished the phacoemulsification and they are placing the lens thinking the case is all over, and now you have a problem because, oh my god, the lens loading was not right, or because I had an infection because it was not loaded really well. Having a safe delivery system for an intraocular lens is probably the lowest hanging fruit available for us surgeons. If there is one system that has changed the game completely, it is definitely the multi-cert. Revolutionized the way that we are doing even the premium IOLs, even the monofocals, even the enhanced monofocals, all of the above. Treating a standard patient for a standard intraocular lens, we were treating them with just monofocals. But going forward, looking at the amount of screen time that people have, looking at the importance that is being given to vision in all the distances, practice of doing enhanced monofocal has to become standard practice. It could come to a day where you might see only enhanced monofocals from all being implanted, and Impress being a really good one from the lot. Well, I really hope that this video was extremely beneficial for every person who's viewing this. I think that there is a larger vision that everybody in the audience wants to address, and that is of building trust within their own community. And when you build trust within your own community, you'll start seeing that benefit come back to you in multiple ways and from every corner. So thank you very much.
So thank you, Ashvin, for that, for those great tips. And you did mention about the enhanced monofocals. So what in your practice is the percentage of use of enhanced monofocals, and what would you like to say about it?
First of all, thank you, ma'am. I think you've been conducting this event extremely well. It's such a well-managed program, and all the questions are so realistic, you know, and it's tough. And all the speakers, really, every time I hear them, I kind of learn. Eric, Supriya, Shreyas, and panelists, unbelievable. Thank you so much. I know we're leaving the best for the last, so we'll come to that, Richard. But in my mind, what's happening right now, ma'am, is that a lot of, and we don't call the shots, right? It's actually the patients and their lifestyle that actually calls the shot in this scenario, especially looking at enhanced monofocal or it be trifocal segment. How it's been growing is purely a sign of the lifestyle change. And when the lifestyle of the general mass audience kind of changes from distance viewing to intermediate and near, which is what it's become, everybody is, I mean, just open your screen time on your phone and you'll know you're spending at least 4 to 5 hours on that device. And anytime you're bored, you're in it. So you're actually spending a lot more time. So even if you're not deciding that, and that's what's really happening. So when that starts defining it, we as doctors, industry as makers of these IOLs, start listening to this thought process, and that's what kind of changed our practice as well, especially when Zoom came into effect and when we started having Zoom calls a lot more, when we started having digital exposure a lot more. It changed my practice to about 20% increase, at least in the enhanced monofocal, and that was in just year 2 after COVID. Now it's about 35 to 40% increase in enhanced monofocals. In fact, even a patient who was willing to go for probably a monofocal is now coming and saying, hey, I heard about this from one friend of mine, and why don't you give me that option? And that's how this whole gamut kind of changes. I do believe that we are moving towards that segment because it has less glare, halos, and all the other side effects of the trifocal. So the low-hanging fruit for us as doctors as well as patients is that segment that we can easily offer this and get through. When it comes to trifocal, there's a little more counseling required. There's a little more hand-holding the patient through that experience required. So I would say 30 to 40% is where it has increased the enhanced monofocal.
Dr. Mahipal sir, can you do have extensive experience with the Impress technology, and are there any specific pathologies or comorbidities where you would rather go for standard monofocals rather than enhanced monofocal, or to say, what are those cases where you wouldn't do enhanced monofocals?
Thank you very much, Dr. Namrata. That's a good question. I think the basic strength of an enhanced monofocal lies in the fact that you can do it with your eyes closed, in the sense that I don't have to bother whether I'm doing a normal monofocal or an enhanced monofocal. I, in my practice, have about, if I leave aside the, even if you add the torics, Impress just now doesn't have a toric, but if I add another company's toric, I think about 85% to 90% of my patients go in for the enhanced monofocal. So that means that there are almost no contraindications for doing an enhanced monofocal. You don't have to talk to the patient about anything. The price difference is not too great, so it's a standard of care for me now. So I'm doing enhanced monofocals in almost all the lenses. It's very rare that I'm doing a normal monofocal. And the patients at times are very, very happy. They may not even need glasses except for fine print, but typically when you're looking at the Impress, it is offering a reduction of the ad from a plus 2.75 to about 1.5 or 1.75. That's the ad they have, and if you do it as a mini monovision from that perspective, they could be N8 and rare at times they can be N6. So to answer your question, I think I don't have any specific contraindications for these patients, which are any patient who comes to me for a cataract surgery and is not going for a trifocal or for an EDOF lens. No glare, no dysphotopsias, and you get reasonable, like what Ashwin was saying, what we are like on the smartphones, like Titial is on the smartphone just now, and you have the laptops. I think this is where it works well.
So 80% you said is enhanced monofocal, and you said possibly no monofocal or very few monofocals. Yeah. So that means 20% is your trifocal use, or is it more?
No, I think you're right on. My practice in trifocals or the EDOF, these two combined would be close to about 20%. I do a lot of LRIs for up to 0.75 diopters, so therefore my toric penetration is about 30-35%. Because a lot of patients fall within the 0.751 this thing, and I do have good outcomes with LRI.
So another question is that if in the fellow eye you have a monofocal or a multifocal lens, then can you implant?
Doesn't matter.
So that's you can implant.
That's again the beauty of it, that you can go ahead and do it even if you have.
So it's a great combination, mix and match lens. Yeah. You can match it with any other lens. Yeah. How do you convince your patients to pay more for this technology, and what promises do you make them?
I don't make any promise. That's my standard. My typical ATV for a cataract surgery is now 1,15,000. So patients who come to me with eyes open, but in any case, see, the point is that that's the good thing. The first monofocal that came into the country, I happened to be on the global advisory board, and I told them, let's make it to the standard of care. So the difference between a monofocal and an enhanced monofocal was only 4,000-5,000 rupees. So there isn't much convincing or anything that you have to really ask them to do. Once the companies make a big difference, like for example, now you have an EDOF lens or you have a trifocal, and that cost is 4 times or 5 times, that's when you have to convince. But if the differential is only 30-40%, that's really not something. And patients are nowadays willing to pay. It's not, it also depends on the type of practice that you have. So that's what it is.
Okay, so I think we've had a great panel, because what insights you have learned here are not written in books. Nobody tells you, and they don't come from didactic lectures, they don't come from surgical videos, but they come out of experience. And I think that way Hoya has done a great job by getting all the experienced minds on the panel. One last word from Dr. Sri Ganesh about micro mini monovision.
Yeah, I use the Hoya Impress, and you can do a micro mini monovision about 3/4 of a diopter to 1 diopter, and if you do this, then most patients would not require glasses. Most of them are able to read N6 at 40 centimeters in my experience, because the Hoya gives about 1 to 1.25 diopters of depth of field depending upon the pupil size, and then if you add another 3/4 to 1 diopter, then it's almost 2.25 diopters. So at 40 centimeters, they're quite comfortable reading. And this is a very good approach. Then they have spectacle-free vision, they don't have any dysphotopsias at night, and the patient satisfaction is very good. So you don't promise them that you can get rid of reading glasses, but you can tell them that I'll kind of make a little bit of adjustment in the second eye to help you see things a little better for near. And then when they're able to read N6 and don't need glasses, then they're thrilled, because they haven't paid so much as a trifocal, but they've got the benefit, and it works very well. Okay. Plus, I think it'll become the standard of care, because now you see so many patients post-LASIK who are coming in for surgery. And the advanced monofocals are a little more forgiving for small errors in biometry. And this actually also is an advantage over standard monofocals.
So a forgiving lens is always more, you can say, easy and for our comfort zone, and so that